Welcome everyone. Thank you for joining us today for this Health Foundation and King's Fund webinar on the future of public health and population health leadership. My name's Gwen Nightingale and I'm Assistant Director in the Healthy Lives team at the Health Foundation. The trajectories around widening health inequalities and stalling life expectancy, alongside the opportunities presented by a new government hungry to show their worth, means that this is a really great time to be discussing this issue. Many of you on this session will be very aware about how improving health and reducing health inequalities requires action far beyond healthcare to strengthen the building blocks of health. So things like creating good homes, stable jobs, and enabling access to healthy, affordable food. And all of these challenges need the expertise and leadership of public health and population health professionals at national, regional, and local level. So in this webinar, we will be exploring the learning from the King's Fund's recent report, Public Health and Population Health Leading Together, which was funded by the Health Foundation. We've got a really great session planned with a set of esteemed speakers. So over the session, we're going to be hearing from Dave Buck, who's Senior Policy Fellow at the King's Fund, Edward Kanunga, who's the Director of Transformation and Population Health Management at North of England Care System Support, and he's also Director of Population Health Management at NHS North East and North Cumbria ICB. We'll hear from Sarah Price, who is the Director of Public Health at NHS England. And finally, we'll hear from Matt Ashton, who is the Director of Public Health at Liverpool City Council. If you'd like to join in the discussion, we'll be taking questions after we've heard from the speakers, and please use the question and answer box at the bottom of your screen to submit these questions. We've got Luca Tiratelli, who is a senior researcher from the King's Fund in the background, and he worked on the report with Dave, and he's poised to respond to any specific questions about the report in the chat. Viewers can upvote questions that you'd like to see answered by clicking on the thumbs up icon by the question in the Q&A function, and we'll try and answer the most popular questions as well as some that catch our eye. And the final bit of housekeeping is that this event is being recorded and a video will be available on our website within 24 hours and a subtitled version will follow afterwards. So if you enjoy the session, you can let your peers and colleagues know about it. So that's it from me for now. I'm going to hand over to Dave, who's going to remind us of the key points that arose from the King's Fund report. Thanks, Dave.
Thank you very much, Gwen. And just to say, it was really great to do this piece of work. Thanks for the support of the King's Fund and yourself. As you can see on this early slide, this is written by myself, Luca, who is on the call, as Gwen says, and our colleague Cheryl. And I'm just going to take you through some of the key points, as Gwen said. So next slide, please. So one question, I think Gwen has touched on some of this already, but is why did we do this? Why are we interested in doing this piece of work and asking the questions that we did? And I think there are three key aspects to this. One is public health has been at an inflection point. Some of you know that we did some previous work, again supported by the Health Foundation, very grateful for, with the Health Foundation, looking at the role of directors of public health and their teams during the early year or so of COVID. And obviously that was a very intense period, but directors of public health in particular became much more broadly known and in some cases more influential perhaps in their local systems than they had been previously because of the exposure and their efforts and those of their teams during COVID. So there's a sense of directors of public health sort of knowledge and influence perhaps being larger, being much more influential in their local system. So that's one sort of strand about actually understanding directors of public health and their roles and influence over time, and coming out of COVID in the economic circumstances in which we are in and still in to some extent. Secondly, a strand around emergence of population health, particularly in integrated care systems, and particularly in the NHS side of integrated care systems, including new really senior leadership roles, such as directors of population health or directors of population health and health equity, or directors of population health management, as we have Edward on the call. So there's an emerging leadership sort of community, and around them other people with population health type roles. And we're very interested in what that means in terms of what are those roles and how do they work, how do they influence with directors of public health and similar in local government. And underpinning this was, I guess, an optimism from us that there was a real opportunity for strong, cohesive and aligned leadership for the population's health or for the public's health, whichever of those words that you'd like to use. So that was the sort of like the setting for the piece of work, and it was a qualitative project, looking at how people's views on these themes and strands, and what is happening in practice, because this is very, very emergent. And we did that through the ways that you may imagine, through a large number of round tables, actually a large number. So there's a lot of, first thing to say, there's a lot of engagement, at least we hope so, from ourselves, with lots of different sorts of groups, with certain sort of roles or perspectives, some case studies at regional ICS and place level, some key stakeholder interviews, and actually, which is again very positive, I think, from our view, engagement with multiple networks, lots and lots of different networks of different sorts of people in different sorts of roles. And we had a very helpful and challenging, in a good way, advisory group throughout the project. Next one, please. So what are the sort of the key things that came across strongly in the work as we were doing it? And I think there are three key. There are lots of, again, as ever, there's lots of nuance in the report, which we probably won't get to in my presentation at least, but maybe in the discussion. Three key things, I think, issues that were there underpinning all of what we heard and interpreted. One was a key lack of clarity, I'll be honest with you, and honest too, and disagreement in some cases of the scope of population health and how it related to public health. A fundamental question for some about what is it. And again, there's more nuance than can be shown in the diagram on the right. But essentially, people have different sorts of, quite a lot of difference in terms of this fundamental question. Is population health actually public health by another name? Is population health a subset of public health? Is it the opposite of that public health is a subset of population health, or are they fundamentally different? And I think there were very different perspectives on this, partly driven by who the person was holding the and their role and their background, partly in relation to specific issues, etc. But basically, not a clear agreement on this across the people that we spoke to, and we think that's a challenge and difficult. We're not, as the King's Fund, we're not saying that any one of these particular definitions or ways of thinking about this is correct. What I think we are saying is that actually you need to discuss this in your local systems and be clear about that amongst you, or where your differences are. And if you don't do that, you can get into all sorts of confusion and possible challenges. Secondly, the issue of integrated care systems and in relationship to population health, and the distinction between theory and practice, and a big question about, are integrated care systems really in the business of population health? We know that their key principles that underline the setup of integrated care systems includes, in our view, very helpful steers on population health and health inequalities and the contribution to wider economic and social goals. So at their heart, in principle, when they were set up, but there was some debate amongst the people we talked to about the extent that they were taking that seriously, extent they could take it seriously. What we're not saying is that integrated care systems aren't taking it seriously. There are lots of examples where they are, but there is still debate about that and how that is expressed and how sustainable that is, given the context in which the NHS and local government and integrated care systems exist. So a question there, and that views on that then obviously influence effort in particular in relationships with integrated care systems. And then third, the issue that I've already alluded to: how's the role of the Director of Public Health changing given the context above and coming out of COVID? So questions around that, and obviously then also relate to that questions around capacity, both in directors of public health themselves feeling pulled in different directions, which I think is to some extent is ever the case. And being pulled in different directions means someone wants your influence. So on one level, that's a good thing. But the ability to where to focus, and obviously also around the teams that they work with. So as a result of this, overall, lots of debate, some confusion, and certainly pretty strong views about where we are heading and where we are currently. And that raises quite a lot of issues of specific issues of role, but also of identity, of power, competency, and legitimacy. So really big sort of fundamental philosophical issues as much as practical issues. So a lot of debate in theory. Next slide, please. In practice, actually, those debates are still there, but I would say that actually when we got to practice and we talked to the case studies, there was a lot, and you would want to see this, wouldn't you? A lot of people getting on with it in a way. So yes, that debate still exists, but actually people, at least the people we spoke to, were navigating this sort of theoretical challenge and getting on with the business. And you'll see some graphs on the right hand side. I'll talk a little bit about them in a minute. But essentially, scale and configuration, how the local system works, actually trumps all of those theoretical issues in a way, and in a practical perspective, and defines what directors of population health and their equivalent particularly are and do, and how they relate to public health leaders in local government and elsewhere, including in the NHS. And we set out some examples in the report for you to see what that means in different sorts of scales and complexities of region, ICS and place, and also the sorts of roles that particularly these emergent population health leaders seem to be taking up. And there are different sort of versions of this, the sort of roles that they take up. And the graphs that you can see and we're very fortunate, which is fantastic. The two graphs actually come from, the top one comes from the Association of Directors of Public Health, who did a survey of the relationship between DPHs and integrated care systems. And this shows you the sort of like the strength of the relationships between directors of public health and their population health sort of colleagues in their local ICSs. And actually, this was, I interpret this as actually pretty positive in terms of where those bar charts are. So to some extent, some of what we pick up in some of the debate perhaps is slightly different from when you actually report your actual direct relationship and how it's actually working for you in practice. And the second was the top chart there. The second chart underneath was, we're really fortunate and very grateful that the provider public health network, I always get this mixed up, so apologies if anyone is on the call particularly. I think it's the provider public health network. I sometimes think it's the public health provider network. So apologies for that. But the association of public health leaders and public health professionals, don't have to be leaders, actually working in the NHS, what their views were on the main roles of directors of population health, if they were directors of population health equipment in their system, the sort of roles that they were taking up. So were they focused on health inequalities, population health management, wider determinants of health, etc. And so that was some insight in the report about sort of how the role is being defined and how that relates to existing public health leaders. So in practice, I think the summary is actually, at least from the work that we did, we recognize that some of this is, we only spoke to certain aspects of practice, but I think reinforced by this external insight too, and some of the network conversations that we had with lots of other sort of folk. It's sort of emerging and evolving. Yes, there are lots of tensions, but actually things are getting on. So next slide, please, and I need to move on. So at the end of the report, hopefully there's some, I guess I should want to leave you with is actually there's quite a lot of practice, hopefully, in the report that'll be useful for you to see what's happening elsewhere. But we came out at the back end of the report with some recommendations. I think when we went into this piece of work, we weren't set on saying the King's Fund's got to come up with a set of recommendations. This was an exploratory piece of work to understand what is happening. And if recommendations were relevant coming out of this, then we said we may make them, but we weren't set on making a list of recommendations. But we did make some recommendations. I think they're quite limited. I don't think we necessarily need King's Fund saying you need to do 10 different things, but the sort of things, again, you can see it in the report. I do think we did think that people are looking for frameworks and guidance on population health, and we felt that people thought there was a bit of an unhelpful vacuum, sort of nationally. That doesn't mean that they want, and this is tricky. They didn't, and there was difference of opinion on this, but most people didn't want this, the public health leaders, be that NHS England or the faculty or ADPH or whoever, to say this is the way to do it. But they did want some sort of guidance and frameworks about different ways, particularly the relationship and the roles and the responsibilities and to some extent the competencies between population and public health. They were looking for something. They were looking for something from each other, but they thought that the national bodies could actually help that and help them do that rather than direct them. There's a critical underpinning fact here about funding and workforce capacity in public health. And we hear, beyond the report, we hear lots of, in the report, but also beyond it, lots of challenges around actually filling posts, and that causes competition between population health and public health. So the fundamental driver of some of the issues is around capacity and lack of capacity. We also, as you might imagine, say ICSs, we really do want the government and ICSs and government to send a message to stick to the principles that were at the inception of integrated care systems. What are they for? That must be about improving population health as well as more NHS standard delivery type issues. And then the final thing is actually more national sharing of emerging practice. It's great to see, if you go to the Faculty of Public Health's website, there are some examples of practice, but we need more. People are looking for more and models of how this can work in different sorts of circumstances. There are also principles for system partners where we drew from the case studies and other insight in particular. And I think one of the key ones there actually was about being explicit, taking the time to talk about roles and responsibilities and relationships where we find good progress. People actually stand back, take the time, and actually talk to each other from the public health and population health worlds and sort things out. That sort of sounds obvious, doesn't it? But often there isn't time to do that, but you need to carve that time out. Next slide, please. We're coming to the end now, you'll be glad to know. So I think my final point and our final point is to go back to the opportunity. So we really do think this is an opportunity. We have a new government with lots of challenges, still emerging on its policy. We have a 10-year NHS plan. We have a health missions. The health missions work, I think, is a little bit behind in terms of, at least publicly, in terms of the 10-year NHS plan end of things, or 10-year health plan, depending on what we think it's called. But to take advantage of any of that real sort of policy impetus really requires a demonstration of aligned and confident public health and population health leadership. So there's a real opportunity here. How any of those things are delivered below national government level will rely on a really strong, coherent, aligned public health and population health leadership in our view. But, and there's always buts, aren't there? There's a real fragility, I think, in our existing leadership and workforce. It's under extreme pressure. Can't escape the fact there's lack of capacity and facing uncertainty. And that often makes collaboration much more difficult than if we're not in those sorts of times. I think one thing that we did not go into this piece of work looking for, but which came out of it, was around people's well-being. And given what I've just said up there, we shouldn't be surprised about that. But nonetheless, the effects, and in particular the effects of COVID on the workforce and the relentlessness of what's followed, is still there. So we have an under stress workforce which is still coming through the trauma and the impacts of COVID. So which expresses itself in all sorts of ways. And the final points we may want to pick up this in discussion as well are our next workforce. And I say our next workforce, our emerging leaders, and we did talk to some emerging leaders and public health consultants and people like that, are increasingly uncertain about making sense of their future role and the choices that it faces, given the emergence of particular population health. So that raises some challenges and some opportunities as well. But there's sort of quite a lot of uncertainty around at the moment. And so I think all of this sort of like points to people are really looking for leadership from our leaders in the public health and the population health system. So to help create some sense of direction, not saying this is where you have to go, but helping people find their way through some of these opportunities and some of the challenges that come alongside that. So thank you very much for bearing with me. Obviously, there's a lot more nuance in the report, but hopefully it'll be of interest to you. And back to Gwen.
Great, thanks, Dave, for that really interesting overview. Before we get on to the main questions, I'm just going to open up the discussion to the other panelists and to hear their views and reflections on some of the issues that have been raised and are coming out of the report. So Edward, you obviously have an inside view on the work inside integrated care structures. What's your experience of how the role of public health management works to support decision making across the ICS, and how does this connect with the role of the directors of public health and their teams in local authorities?
Yeah, great. Thanks, Gwen, and thanks, Dave, for your presentation. I think there's a lot you've covered in there that we could spend the whole morning reflecting on. But I'm just going to share with you just my experience and my reflections working across the Northeast and North Cumbria ICS system. So the largest ICS in the country, we've got 14 local authorities, and we have got a population of about 3.2 million. So quite a huge and vast geography that we cover. But we work very closely with the directors of public health. We have the Association of Directors of Public Health, who we build our approach on population health across the ICS on the foundations of many years of collaborative working. And I guess that's one thing that I would emphasize, which is whilst kind of titles like population health management might appear new, we shouldn't kind of be swayed by the new and shiny and explore them at the expense of building on existing relationships. Population health management is not new. I have worked in public health, and we have been doing this stuff for many, many years. So I think demystifying and having a common understanding of what are we trying to achieve across the system, and how can we harness, whether it is new powers, new resources, to continue on the journey that we have been on for a long time, which is about improving the health of our population. But how do we use data and how do we use the local stories and narrative to really get to understand the complexity and the challenges that our population faces, so that our interventions are as targeted and as impactful as possible? So I see population health management as an opportunity for us to harness many developments on different fronts that progress the work that we have been trying to do for many, many years. If you think about the historic approach of using data, has been pretty much informed on hindsight. So we present data to tell people and the system about what happened. But we now have got more computational power. We've now got the opportunity for systems to talk to each other, and for that to happen at a much faster pace, so that we're moving from hindsight to more insight, what is happening, as well as understanding how we've got there and what has happened. But better still, we can then build on that to have more foresight and project into the future and look at the different scenarios and use that data, the insights, to really focus our decisions on the things that will make the biggest difference. So for me, I see my role as being part of the system and how we need to work collaboratively across the system to improve the health of the population. I think Dave highlighted the lack of clarity I think if we're not very careful, it can become divisive. I think we might expend too much energy and effort, which might be misdirected. So in our system, we agree that we are one public health system, and accepting that we find ourselves in different parts of the system. How do we harness that position to make the maximum possible impact on the population? As a system, we agreed on a framework that we basically said, as far as the NHS is concerned, there are the areas where the NHS needs to lead, whether it is decisions about the commissioning of healthcare or the delivery of healthcare. That is a unique contribution that the NHS brings to the table in terms of improving population health. So how do we work together to make sure that those decisions are going to achieve the maximum possible impact? Then the second area that we talked about is there are areas where the NHS can collaborate or needs to collaborate to work across with others to make sure that we're giving people a holistic experience. So if you think about housing and this links with health, when you think about the impact of fuel poverty, we can use some of the data we have in the NHS to really identify those people most impacted by some of these issues and target them with the right interventions. And then the third area we've talked about is there are areas where the NHS can advocate. So how do they amplify the voices, but not seek to interfere? NHS is not best placed to sort out housing issues or education, but it can use the power of the respect that it has to raise issues on areas of social determinants that are resulting in increasing demands and poor outcomes for the population. So we kind of arrived at that working together as a system with directors of public health and their teams, the senior leadership team within our ICB and the wider ICP partnership to make sure that we've got a consistent way of looking at that. Then we agreed on which areas do we need to focus on. So we recently published our clinical strategic plan, which was a data-driven approach to understand the clinical needs of our population and how we intervene. We're also using data to support patients waiting for surgery and identifying those patients who without an intervention will deteriorate and cannot have the maximum benefit from surgery. And recently we've started talking about how we use the work and health opportunities to really identify those people who will need either health interventions or employment interventions and work together using the power of linked data sets to improve the outcomes for those population groups. So I guess, Gwen, from my experience, I think if you treat this as a new agenda, then it will set you apart. But if you see this as a progression of the work that systems have been doing, you can harness the many opportunities that this presents, and you can have an approach that works for your system, as David has highlighted. And perhaps we can share the learning on what is working up and down the country. So I'll stop there, Gwen, and happy to come back later on.
Super, thank you for that, and I'm sure that will generate some more questions in the chat. I'm going to turn to Sarah next. Sarah, you're obviously at NHS England. From your perspective, what's the future of public health and population health leadership? What does it look like, particularly in relation to the capabilities and the capacities required in the NHS?
Thanks, Gwen. And I think what I'm going to say sort of resonates with what Edward's just been talking about, but maybe from a slightly different angle. I think one of the things that I kind of really took from the report was the point about us being a public health family. And by kind of talking about what's the NHS's role, what's local government's role, what's others' role, I think we fragment ourselves in a way that perhaps isn't as helpful as it could be. So we've all got something to offer. We're all working towards the same goal. So it's up to public health leaders to make things work. We need to be the glue that joins things together. And I would heartily agree with Edward that we've all got something to offer. And it's by working in that joined up way that we're going to make a difference. From an NHS point of view, for ICSs and ICBs, we need to be able to draw on the expertise of the DPHs. Even if we appoint people to population health or public health roles, we aren't going to be able to do things on our own. We don't have the expertise. Edward just talked about housing. We don't have the expertise or the capacity to be able to do that. And therefore, by working together in that wider leadership way, I think we are in a position to be able to really influence. And public health input is both technical and leadership. Our technical skills are very important. And from the NHS point of view, those healthcare public health skills around value, effectiveness, efficiency, that allocative efficiency type of question is something that perhaps we haven't done as much of, and perhaps was what was picked up through the provider network survey that Dave referred to, that we need to be the kind of upstream view for the NHS and really making the argument that we're thinking differently. So a strong voice, providing the evidence and the data, and the ammunition that executives and non-executives on boards need to be able to really support the preventative approach, the health inequalities approach, and making the right choices. The importance about having input at neighbourhood, place, as well as systems, I think, is also key. Trusts, NHS trusts, are increasingly appointing public health consultants, sometimes on their own. They need to be part of a much wider group. Hopefully there are some others like Edward who are doing joint roles, whether it's with local authority and with the ICB, or with a provider in the ICB. We're seeing that as a growing model, and making sure we've got a common narrative at that place, system, lead, neighbourhood level, I think is really important. The other thing I think we need to really focus in on is the fact that the NHS has suddenly realised again that it has a key role to play in prevention, whether it's through the Darcy review or whatever. And that's something we need to grab hold of and not let pass. So I don't know if anyone heard Amanda Pritchard's speech to the NHS providers on Tuesday, but she's talked a bit about what the role of different organisations within the NHS are. She talked about ICBs having more emphasis on prevention and care in the community, and that NHS England should have more of oversight role with its regulator hat on. And she was absolutely clear that there will be no reorganisations. And I think from all of that, we need to really draw on our influence in the 10-year health plan, really emphasise the role of ICBs and in prevention, and make that join up at local level, regionally and nationally. The provider network, I think, are an opportunity to join in that family at local level. I absolutely hear the call for a definition of population and public health from the report. But as Edward said, let's not spend a lot of time doing that, but let's focus our influence and leadership to take the opportunity we've got now with an increased interest in prevention, an increased interest in reducing health inequalities, and hold our colleagues to their primary purpose, which is to improve health outcomes. We are doing a piece of work across NHS England, Faculty of Public Health, Association of Directors of Public Health, to try and pick up on some of the information that's come out of these surveys. How do you support ICBs to best effect? How do you make sure that the narrative is clear? And how do you strengthen the role of public health in all of this? Thanks, Gwen. I'll leave it there.
Great, thanks for that. Thanks for that, Sarah. Some really interesting things there. And I think kind of one of the things that sticks with me about what you said about that kind of focus on the public health family, and we've had a couple of questions in the chat on that we'll pick up in a moment. So finally, I'm going to turn to Matt. I'm really interested to know how the relationship between public health and population health in your local system has been developing. And could you perhaps tell us a little bit more about how that's been going, but also where you would like it to go next?
Yeah, thank you. Hi, Gwen. And I guess a couple of reflections from me first. So my view actually is that population health and public health are the same thing. I think it aligns probably to both Model 1 and Model 2 in the report, in that in effect they're the same thing, but where do different systems focus their efforts? And the NHS's focus on population health does tend to naturally be on healthcare, public health. So that's how I would frame it. They are in effect the same thing. I think there's an important element, though, that we talk about public health being everybody's business, rightly so, but we also need to make sure that we've got the specialists and the experts in the room leading what that agenda is. So, for example, you wouldn't have a member of the general public doing eye surgery. In a normal country, you wouldn't have an anti-vaxxer leading on a vaccination strategy or on health policy. And similarly, we shouldn't have non-public health professionals leading on population health within the NHS. Now, largely we don't, but I think it's an important caveat to make. There are implications for that, as David said in the report. So, capacity issues within the public health workforce, making sure we are properly investing in public health, population health workforces that are properly trained, skilled, and experienced to be able to make those decisions. And then I think, although I've said that, at risk of contradicting myself, I think language does matter. And we saw a little bit of that play out around equity, equality, and disparities under the previous government. I think language does matter, but I do think actions matter more. So then it is much more about how we come together as that public health, population health family to actually tackle the big, wicked issues that this country is facing and that our health systems are facing. And then within that space, I would say directors of public health are key. So we are, laid down statutory roles, laid down legislation, lead advisor on health matters to the local population. And so, although in my example, I'm employed by Liverpool City Council, I'm not the Director of Public Health for Liverpool City Council, I'm the Director of Public Health for Liverpool. And so my role is to work with all partners in that space to address some of those health challenges we face. I think there's an element then moving away from clarity onto the role of the ICS and ICBs. I think there's absolutely essential that we've had some of those principles of prevention and inequalities laid down in what areas need to focus on. I think there is also a reality that most areas are focusing on the cliff edge type conversations. So how do we make sure that people are being treated when they need to be treated rather than doing the upstream conversation? And so, and as Sarah said, the NHS by itself can't have all these conversations, because if you think about public health as being healthcare, health protection, health improvement, and wider determinants, then it's much bigger than just the NHS. Broadly, health is created within communities and healthcare is provided in the NHS, and obviously blurred lines in the middle of there. So then it becomes, how do we work together as a system to address those system challenges? And I think, Gwen, to finally kind of answer the question you posed me, that there is really good practice happening up and down the country. We're really proud of the work that we're doing in Cheshire and Merseyside. So Cheshire and Merseyside, ICB, 2.5 million people, 9 local authority areas. So for a long time, we've had champs, 9 directors of public health working together. Actually, now we have 10 directors. Ian Ashworth is the Director of Population Health for Cheshire and Merseyside ICB, and he's part of that champs gang. So we work together on our strategy, on our priorities, and making sure we focus our work in the right area. And we're really pleased with the work we're doing, including very specific population health programs, including, for example, on tobacco, on alcohol, on marmot work. So you can do really good stuff, despite the fact there is it is a difficult environment and difficult context. I think my reflection is probably broader than that, though. It's probably that balanced reward type conversations. The reality is, unless we get really, really serious about prevention and really serious around inequalities, we are not going to reduce the level of demand that our NHS is currently experiencing. And the NHS needs to do more in that space, but actually all of us need to be able to do more in that space. And you can't do that without the proper resources, the proper focus, and the proper kind of mandate, both locally and nationally. Thank you.
Great, thank you. Thanks very much for that, Matt, and for keeping it so succinct. So we now move to the portion of the webinar where where's the opportunity to ask questions. We've had quite a stream of questions, so thank you for people who've sent them through. Do continue to ask them if things come to mind. I think kind of where I'm going to start, it's a bit of a theme that you've touched on in your presentations, and has also come up in a number of questions. And that's around clarity of roles and governance, and kind of how people are being held to account. And I was interested to understand a little bit more about what you are personally doing and within your organisations to get that clarity that will make the relationships easier and more straightforward. And perhaps one thing that you might be looking outside of your direct control. But before I come to people operating in the field, Dave, perhaps I wonder if there've been any reflections on that from the research about what you were hearing that people wanted or needed.
There were lots of things, and I think lots of differences of view. And I think, Matt's made it clear, and I think many people do think that directors of population health equivalent need to be public health trained in some form. That's a really tricky one. I think they certainly need, my personal view, by the way, I'm not public health trained, so I should say I shouldn't be on the call really talking about population health in that, if but I personally think that's obviously really desirable. Is it in all cases essential is a question I would have, and that to me depends on the role. So I think there are very different roles that are emerging in population health, and is a director of population health role a single thing, and can it be defined in the same way as a director of public health? I think is a big question. So particularly, and I think Sarah said, clearly there's technical expertise, there's experience, there's context, and there's leadership. And I think some of the director of population health roles are principally about leadership. And a lot of leadership is about recognizing technical expertise in people around you, drawing in people with public health expertise and letting them lead. So I think it partly depends for me on how these roles are actually developing. At the moment, they're evolving slightly different ways in different places, I think. I think underlying this is actually, I say that, this is what I think. Do I really know? No, because we haven't got, one of the things that I wished we'd done was to really actually in this piece of work was to actually get some really in-depth job descriptions, which we didn't do. So if we had our time again to actually understand what is the role description, and to what extent is that about actually you definitely need the a certain level of expertise and competency. And I know there are ongoing conversations, which I think is welcome, about some of that, amongst some of our leaders. So I welcome the conversation, but am I as convinced or clear in my own mind? I'm happy to be convinced, by the way, about that. I don't know. I'm a bit more open, a bit more uncertain.
Thanks for that, Dave. And perhaps, Sarah, if I could turn to you, I wonder kind of what's happening within NHS England and within your role to help clarify those roles within the family that you described.
So what we're trying to do at the moment is really bring the family together within the NHS, because I think it has been quite disparate, and there are lots of people working in quite isolated places, i.e. a single consultant working within an NHS trust. So the provider network that Dave referred to earlier do a lot to do that, and they've really grown in strength. They've been going for 10 years now, which just shows you how things have changed. I think they started off with 20 people and now they've got over 150. So, it is a growing area of public health practice. But I suppose one of the piece of work that I referred to that we're doing with the faculty and with ADSPH is really to think about what support do systems need? How do we ensure that ICBs are drawing on the technical expertise of public health to do their jobs, as well as the leadership? And different models will work. And Matt's model that he described in Cheshire and Mersey their DPH in the ICB is, or Director of Population Health is working to an executive who will then be in a position sitting on the board to be able to influence more broadly. Now, if that relationship works well and that expertise is fed up, then you're going to have a really different approach to somewhere where you haven't got that being fed up and fed in. So it depends on where the Director of Population Health is, what influence they've got, what technical expertise they can draw on. And I think what we're clear about is that we need to ensure that systems as a whole have access to all of that. And together, as organisations at a national level, what can we do to support systems to be able to ensure they've got all of that in place, whether it's peer development or additional capacity or building of relationships.
Great, thanks for that, Sarah. And Matt, there might be some things that you kind of want to respond to in relation to the points that you've just heard. But in addition to that, there have been a couple of comments in the questions about workforce and both workforce capacity and there perhaps not being enough people to fill the roles that are required who have got the necessary public health qualifications, but also some comments about how jobs can be hard to find even with the qualifications. So yeah, kind of interested for your take on that and perhaps some of the steps that might be needed going forward.
Yeah, thank you. Well, first of all, of course, David, I would never dream of kicking you off any call whatsoever. I think there is a difference between statutory roles in local government and high-profile roles in the NHS who will be held to account for the roles they're doing and the fantastic work you do championing public health. So I think we just need to be clear about kind of what the purpose of the roles is. We have very deliberately positioned Ian Ashworth as the public health leader within our local health system, in the same way as Edward is in his, and that absolutely then allows those conversations to happen in the way that Sarah has described. So I'm a big fan of the model we've created. I recognise that isn't in place everywhere, but it is in our system. But of course, that then leads to workforce challenges, not only at a Director of Population Health level, but we have consultants in public health working in our local trusts, and they're part of our network of healthcare public health leaders. But what we end up doing if we don't have enough trained specialists is we rob Peter to pay Paul. We move people around the system rather than creating more people. So the obvious answer is we need to train more public health leaders. And that's the same as it would be in any medical or clinical profession. When you have a workforce shortage, you invest in that workforce and you train more people. We don't have enough of a pipeline at the moment, whether that's through the training scheme or whether it's through the portfolio route, to meet the current demand. So I would absolutely be saying, let's get serious about training the next generation of public health leaders. What I would also say is the public health family is fantastic. So it isn't just about public health consultants or directors in public health. It's about how you give opportunities to these amazing people, both clinical and non-clinical, to lead that public health agenda. So it really is about harnessing the skills and expertise of everybody in the system to allow them to focus on prevention and inequalities. And if I may just touch back on definitions again and impact, I think that is where we do need to do a bit of work to, when everyone says prevention is really important, they're not always talking about the same thing, whether that's primary, secondary, tertiary. So we do need to define a few spaces for people to operate in separately and a few spaces for people to operate in together. And then that, of course, comes back fundamentally to what makes a difference to a population's health. Where do we need to focus our resources to maximise the return? And that's why I would say that relationship between local government and the NHS is absolutely essential. Unless we get the balance of resources right, we're always going to be putting out the fires and not actually creating health in the first place.
Thanks for that, Matt. So some really clear messages there around the need for more training in public health. Edward, perhaps if I can come to you. some of the comments that we've had and questions have been kind of asking about how you get started and perhaps how you build a successful system and get kind of that feels aligned and working together. So I wondered if you could perhaps say a little bit more about how you built that alignment that you've got within your system, and perhaps if people are in areas or teams where it feels like that isn't happening, where might they start? Kind of what are some good actions that will deliver a quick return and give people that good feeling that's needed to carry on with it?
Yeah, thanks, Gwen. And I think some of that has already been covered by colleagues, so I will not repeat what colleagues have highlighted. But when you come back to kind of the definition of public health, and I won't recite all of it, but the last bit talks about organized efforts of society. So I think for me, the starting point is understanding your system and understanding who are the players in the system and getting people together. You cannot design this in isolation and hope that it will all come together and make sense. Build on existing arrangements. In most regions, you've got an ADPH network. Link up with them, bring people together and have those conversations. Understand where your public health capacity is in. So in our system, we have obviously local authorities led by directors of public health. We do have public health consultants working in the NHS, in the providers. We do have colleagues within the Office for Health Improvement and Disparities in OID. We've got colleagues in AXA. We've got academic colleagues working on this public health agenda. We've got people in the voluntary and community sector. I guess it's bring that family together alongside NHS colleagues, to have a shared understanding of the challenges and the opportunities for your population. Have the same language, if you like. I think Matt has already talked about, someone talks about prevention, you could have different definitions. So agree, what do we mean by prevention? What do we mean by inequalities? And what do we think our roles are in this whole ambition to improve the health of our population? And how do we avoid duplication? But how do we coordinate this? And that allows you then to walk away at least knowing who's doing what and being very clear on how do we maximize on the unique contribution that each part of the system needs to bring in. In Northeast and North Cumbria, we established a program called Healthier and Fairer program, and that's been useful in bringing people together. It is jointly chaired by our medical director and our lead director of public health, who also happens to chair the Association of Directors of Public Health. But the work streams that sit below that are not just limited to public health consultants. We bring our practitioners in. We bring our apprentices in to really maximize on the capacity that we have across the system to harness all that energy and align it so that we can progress this agenda going forward. So I think if you were to ask me, where do you start? I'll say get people together, build the relationships, get talking about this, and co-produce your population health plan together rather than building it separately and hope that it will miraculously come together.
Thanks for that, Edward. Some really practical tips. And I think you've also touched on another one of the questions that we'd had about leadership and who is a leader in this space, and that fact that we're all leaders, and it's about finding that space that we best occupy, and that we can look up sometimes and hope to get particular answers from the top and direction, but there are also steps that everybody in the system can play to kind of contribute, particularly from a local perspective. I mean, I think that's one of the real strengths about being involved in things locally. You often have a lot more control locally than you do centrally, and I say that as somebody who spent much of my career working in central governments. So I'm going to shift the questions slightly. We've had a couple that have linked to resources, so kind of issues coming up about how can what steps can be taken to get government to focus more on preventative activity. Is this about making an economic case, or is it about a case for enabling people to have the best quality lives? And then also questions around how we might direct money towards prevention, with the suggestion that ring fencing might work. And so interested for views on kind of building the case for prevention, and perhaps as well what's been working locally, and what you might be looking for, perhaps if you are looking back up into the centre. So Matt, I'll come to you first.
Thank you. Sorry. So yes, we do need to direct the resources into the right place. This is not a new conversation. It's been happening for a while. And I think that's worth reflecting in a report that I wrote for Liverpool this year. You know, health in Liverpool's been poor for 30, 40 years. It's poor right now, and if we keep on doing what we've been doing so far, it's still going to be poor by the time we get to 2040. So very, very challenging situations. And then the context, obviously, of the public health grant being reduced by 26% over the last 8-9 years does not help the situation, especially at a time when local government funding is being cut. I think the NHS is experiencing financial pain now. It probably, and it's been, obviously having to work on an efficiency agenda for a while, but it's probably as bad as it's ever been in the NHS, whereas local government's been experiencing that for some time. And I think Health Foundation did some work a while ago asking the general public where they would most value their health monies being spent, and kind of unsurprisingly, the top answers in there were A&E and primary care, being able to see somebody when they want to see them. So unfortunately, the general public don't always understand the value of prevention either, and politicians obviously are driven by the voices in our communities. So I think there is something about helping people to understand the value and the benefit of public health more. The business cases, the return on investment, the value for money stuff is all really clear. The evidence base is there. We don't need to have that argument. We've been having it for 10 years and it hasn't made a difference. So actually, I think there is just something about people valuing the importance of that public health agenda more, which hopefully will lead to a greater focus on it. What I would say is, under the new government, we are seeing at a national level a greater focus on population health measures. They just, in my view, they just need to be able to translate into local action as well. So any health outcomes will be influenced both by what happens nationally and also by what happens locally. So we need to have the resources and the focus at both those levels too.
Great, thanks for that, Matt. And certainly the polling that we do at the Health Foundation on a rolling basis around some of the public health interventions, as you say, around action on smoking, for example, you do see that there's strong support. We also had it was the year prior to the election, we did some work with Public First, particularly in red wall areas, and what we did see there was, I can't claim it was a shift because we weren't tracking it over time, but there was a different kind of feeling, kind of recognising the role that councils could play in improving health. So I think from my perspective, it feels like there's perhaps an open door there to be pushing on, rather than massive resistance to understand what investment might be needed in prevention and in public health. But Dave, would you like to come in?
Yeah, thanks, and I agree with what Matt said there. I think there's several things here. One is we need better measurement, and you're never going to get perfect measurement. That's the first thing to say. Better, and what I mean by better, I mean consistent measurement of prevention. And we know that the NHS has not measured prevention. We know it's measured in local government through the public health grant. I know that's not all prevention, but if it's transparent, you can see what's happening to it. So we need to get better at measuring it, making some decisions about what we mean by it, and then measure consistently over time, so at least track. So then it becomes part of a public debate in a way that it is less so now. I think that this is really on the horns of a dilemma about what argument to use for prevention. So I'll be more optimistic in a minute, but I by background, I'm a health economist, and so I hear all the time the only prevention has to jump a higher bar than treatment, because we see it as an instrument to reducing utilization of demand or saving money, principally in the NHS, not necessarily in the NHS, usually within very short time frames. Some prevention can do that. Most can't do that. Much prevention is very cost effective, as Matt said. We know from the University of York that the the money going through the public health grant and local government is 3 to 4 times cost effective as sort of if you stuck the same money in the NHS baseline. But the arguments you need in order to get attention for prevention is the short-term utilisation reduction, the short-term cost saving. So we're systematically under investing and also subverting where the prevention money goes. So we have to, and this is really tough, we have to get our finance colleagues, our colleagues in places like SIPA, the Healthcare Finance Managers Association, to come to the table around, and also our finance directors really, to say actually what prevention delivers you is return on investment, where the return is cost-effective health gain, just as you would want in treatment services. So I think we're forced to fight to argue on a short-term basis, and if we don't do that, we don't get the money prevention. But that will just leave us in the same place time after time after time. And so that's my personal view as a sort of former health economist. I'd also say that actually this does the Department of Health and Social Care can help on this. I hear, and this is all secondhand, so it's not gospel truth, third hand, fourth hand, that every time the Department of Health goes to Treasury and asks for resources, prevention isn't top of the list, and yet it is incredibly cost effective. Most prevention, not all prevention is cost effective, and if it's not cost effective, we shouldn't be doing it, arguably. So it's got to be in the political ask further up the tree. The problem with prevention is it's quite cheap, and so therefore it doesn't cost that much cash compared to treatment. So then we've got all sorts of ironies. We've got to break through that. I also agree about the public voice, and as you all know more than I, Gwen, all your work says that actually, if you talk about very specific things, the public is actually leading the politicians on some of the regulatory aspects of prevention. So this is not all about spending money either. It's about using the other levers that you've got. And in a system with relatively little, well, I say relatively little cash, there's almost 200 billion pounds going to the NHS, isn't there? So like in the next a year or two, we have a lot of cash. It's sort of like it's moving it around. The final point I would say is the 10-year plan and the missions. We've heard far less about the missions publicly than we have about the 10-year plan. So the conversation about the 10-year plan is leading the missions, but there's huge opportunities in the missions in all sorts of ways for prevention, including what will the English devolution potentially look like, and what's the role of prevention there, the role of Matt and Edward, sort of where they are, the role of combined authorities, all sorts of things, the mayoral role. There's all sorts of real interesting stuff going on. And so I'm an optimist, but we've got to change the terms of the debate, I think, is really key. And underlying that, we all come on, is the financial rewards and the incentives for prevention. You can invest in local government, and if the benefits all flow to the NHS, the money doesn't cycle back. And this connects to the sort of like how we get one budget, one place, in an analogy of what we've been talking about, one leadership community around the public health family, and connected to that, the population health leaders. So we've got to work on that. A 10-year plan hopefully gives you the opportunity to do some of that stuff. We know that it's really critical if rhetoric is going to turn into reality.
Great, thanks, Dave. And before I turn to Sarah, there's an opportunity for a shameless plug for the resources that the Health Foundation have got that we've developed with the Framework Institute around having a conversation with health. So I'll put the link in the chat. But if you're having a conversation about health, if you're thinking about engaging the public in those conversations, it presents a frame that can help with that. But Sarah.
Thanks, Gwen. And I suppose there is something about myth busting, because I think there is a widely held view, which isn't correct, that everything's going to happen in 30 years' time if you invest in public health or population health. And there are things, as one of my colleagues pointed out recently, if you give up smoking now, that could reduce the number of people going into hospital this winter. There are some, and it's that kind of language that I think we need to use, certainly in the NHS, with our colleagues around, it's not just nice to have, it will have an impact. And it's that differentiated narrative I think we need to develop in public health. You know, when you're talking to the finance director colleagues, then we need to be able to use language that they understand and that resonates with them. The issue for me on return on investment, and having to, at the moment, trying to make the case for lots of different things, is everyone's looking for cashable saving, and this isn't what we're talking about here. And we've got to have a broader understanding of what we mean by that benefit, and being able to classify that in a much better way. And I think by creating that different narrative, we could potentially do that. Things that people talk to me about a lot already are we need some targets. You know, I can remember being a local DPH and being held to account for premature mortality from cardiovascular disease and from cancer, and having to justify why we weren't improving at the same rate as the rest of the country. And that focuses the mind and it puts effort in. If you don't have that, people feel that it's not as important. So to raise the profile, I think we need to do that. And the other thing I would point to is the OBR report that came out in September, which had a whole, you know, third of it was about prevention and investment in prevention. I nearly fell off my chair. You know, the OBR are saying that prevention is right. Well, the OBR are influencing what the Treasury does. So therefore, we need to be shouting that from, you know, from the trees, really, don't we? We need to be really using that to our advantage. And the final thing I would say is that, you know, we've seen the decimation of the public health grant, but at least it's ring fenced. If it wasn't ring fenced, I don't think there'd be anything there at all. And it's a crude measure, but maybe in the short term, we need to be thinking more about ring fencing. As Dave says, you know, that we're not very good at measuring what we're spending on prevention. If we could hold it together, I think we'd have a better chance of being able to both defend it and argue for more. Thank you.
Great, thanks for that, Sarah. We've got some thinking we're doing around the Treasury and a different way of allocating, of classifying prevention funds that we've been doing as well. That is an important area. So, Edward, I'm going to come to you for reflections on what you've just heard, and then also you can be the first to answer my final question, which is what is your ask from the 10-year NHS plan and the health mission? What are you hoping that comes out from that?
Okay, great. Thanks, Gwen. So I think on the resource allocation and shifting towards prevention, again, I'll just make a plug there for the commissioning support units. So I work in one of the 4 commissioning support units, and we handle a lot of data, healthcare data that on the whole is used for performance management, contracts, and sorting out payments. But actually, there's a lot of value in the data that your CSUs hold. And I've been pleasantly surprised to the extent that within a day, you speak to an analyst and they say, oh, I've got this question. And by the end of the day, they say, is this what you were asking for? We have been able to demonstrate to our local system the impact, certainly from a health inequalities point of view. We've been able to do profiles for people with severe mental illness, and why we then see that huge, at least 20-year gap in life expectancy, because you can see the comorbidities for your population, not just relying on the national figures, and how you can kind of present that at a GP practice level. We've also been able to do work on the waiting well. Sarah talked about prevention is not about investing now and having to wait for 30 years. We are doing that for patients waiting for surgery. That if you support them to quit smoking, if you support them to manage their diabetes, you will get better outcomes. And our data is beginning to show, because we can track them. And that's the benefit, again, of working very closely with your CSU. So I would really encourage our colleagues to reach out, because there's a lot that CSUs can do in this space. Then I think colleagues have already spoken about making the case for prevention. I think having the moral case, which most of us will agree on, prevention makes sense, but a moral case for prevention is not enough. So we need to then build on the financial case and actually use local data and local figures. This is the profile of your population. If you did this, and this is the impact that you will have. We did that for diabetes emergency admissions in County Durham, and said if you reduced your emergency admissions for diabetes complications for people in your third most deprived decile, for people in your most deprived decile to be similar to those in the third most deprived decile, you save £1 million. And I remember the finance director saying, did you just say £1 million? So it's building on the financial case and using the data. You can also present a productivity case. The NHS is focusing on productivity, and actually investing in prevention can provide you with bigger returns on productivity. And then you can also talk about, it makes good sense in terms of how you manage the business and the broader economic argument in terms of all the ambitions for the greater UK PLC. If we want to step back into the position globally in terms of being an economic powerhouse, we can't do that with a population that does not have good health. So I guess what I'm saying is you can't just go in with one narrative. We have to think about how do we use the data, and that for me is where population health management comes in and supports in having many different narratives on how you can shift the focus into prevention and how you can change your resource allocations. Then your question to me on what would I want for Christmas or for the NHS plan? I guess for me, all I want within that is less rhetoric and more clear action. I think we all know, and we have had the rhetoric before. I think very clear and specific actions, I think will go a long way, rather than repeating and recycling the rhetoric we've had before.
Fantastic, thanks, Edward. And Sarah, what's top of your Christmas list?
I'd like a big vision, really. I'd like something that will really create that paradigm shift, not just doing a little bit more of what we already do.
Great, thanks. And Matt?
So the smoking bill is absolutely fantastic. Let's build on that and let's go for alcohol next, including MUP, but also recognise that if we're properly going to address alcohol, it needs actions both nationally and locally. And in order to do the action locally, we need powers and we need resources. On David's point, I absolutely, and Sarah's point, I absolutely think in order to do that, we need to make sure we're properly ring-fencing public health or preventative spend, and we're also measuring it and holding systems and people to account for it.
Great, thanks. And very briefly, Dave?
Right, so I think the government should fully get behind its stated goal about halving healthy life expectancy between regions by half and have a proper plan to deliver it. That's going to be really, really tough, but it relies on the economic and health missions working together and not working against each other. So it also relies on removing the perverse incentives that we see. So we invest in what, say, in local government and on prevention, all the gains flow into the NHS, and yet we can't recycle those. So we need to get those system design principles right to underpin it. And finally, to bring us back to the purpose of this webinar, it relies on the public health family working very strongly with the population of family at local and regional level. So I want the government to recognise that, support that, and invest in the capability and the numbers that are required to actually drive this and influence decision making underneath its health mission in particular.
Great, thanks, Dave. And that's a really good and a neat point to end on. So I'd like to thank all of you all on the panel, and Luca, Caroline, and Sonia in the background. Thank you very much, and to the audience for your participation. We're leaving you with ways in which you can keep in touch, and also there are a handful of links that have been shared where if you've come along to this webinar, you're probably going to be interested in some of these areas of work if you haven't seen them before. We've got information around the future of the public health system, placing health at the heart of government, the frameworks work that I trailed, and also some resources that you might want to use, and we really encourage you to use them. They're free of charge. An evidence hub where we've got a variety of data, and then we've got some really nice infographics that we'd absolutely love if you just copied and pasted them and used them as often as possible, that explains some of the building blocks of health. And the webinar should be available in the next 24 hours on a website if you want to share it with colleagues. And all that's left for me to say is thank you and goodbye and have a lovely weekend.